Hi, everybody. It's Kevin and it's Donna, and welcome to another episode of the Med List. Donna is currently traveling. I was just traveling, and it's kind of end of summer wrap up for everybody. I don't like saying that, Donna, because I want the warm weather to stay. I
Right.
want to enjoy it and be able to soak it up as much as possible. Speaking of soaking it up, the Walker family made a trip to Disneyland and got to enjoy all the things of Mickey Mouse. And we get to talk about some of the Mickey Mouse things that happen in the insurance world with Cristy here coming up soon. But what are you doing, Donna? What's the latest and greatest? And tell us
Yeah.
about your background there.
Yeah. So I am right now in Cincinnati and a little echoey and emptying out my daughter's apartment and bringing her back to Massachusetts for a real job. So how exciting is that, right? but
Super.
but you're right about the whole summer thing. I just read an article on that. Some people think this is the end of the summer, like this last week of August. Others are true to the calendar and don't wait, and they start talking about the end of summer around September 22nd. So I think I'm going to go with that. September 22nd and
September
December.
22nd. I'm going to stick with you. And up here in the Northwest, I feel like if I can get summer until October, then I will take it every single year. The only interesting thing I would say to the audience is, there's lots of transitions in life that are happening kind of this time of year. Kids are going back to school, everything's starting. And one great reason to talk to Cristy here coming up is that you've got kids that are changing over the age gap of now they've got to find their own insurance. They're starting a new job and they're thinking about what are my health benefits going to be like?
Yeah.
People are retiring. This is their last year of work and they're wondering, what am I going to do for those either gap years between now and 65, or they're hitting that Medicare, sweet spot and wondering, what am I going to do with my care and taking care of my family? So really excited for this one. Hope you guys are bringing a pen and pencil because Cristy's always fantastic with lots of good tidbits. And we will talk to you guys in just a second. All right, without further ado, we'll add our esteemed guest to the stage.
Hey, guys.
Hey,
Hello.
Cristy.
So glad you're with us, and thank you for joining us. Today we have Cristy Gupton with us, and Cristy is a nationally recognized employee benefits advisor and has endeavored to solve healthcare challenges for employers since 1998. Cristy has been named twice to Employee Benefits Advisor magazine top 20 women in benefits advising list. In 2017, Cristy was credentialed by the Health Rosetta and Mitigate Partners, groups of the nation's leading healthcare consultants who provide transparent employer-built health plans with direct primary care at the foundation. Cristy is very well established with a bachelor's in public health from UNC, master's in health benefits design and health informatics from University of Lynchburg, and a designation of global financial steward in Wake Forest University's Center for Board Certified Fiduciaries. So many things that you've done in regards to publications and speaking engagements too. The list goes on and on, but I think just two more things I think are so important. I love that you educate employers and employees on being smarter, more informed healthcare consumers. That has been something that I've been trying to do for many, many years myself. So, Cristy, I think that that's wonderful. You're the creator of Sunlight Health Plans, a self-funded plan design for employers, and also the founder and president of Custom Benefit Solutions. So welcome. And boy, we're so excited. I think we've got the lead here in the industry for sure. So welcome, Cristy.
Thank you so much for having me. I really admire you guys. I think, Dave Chase has it right when he says there's the three most trusted professions in America are nurses, doctors, and pharmacists. And so for the work that you guys do in our healthcare system, I applaud and thank you for that.
No, thanks so much, Cristy. And I guess let's start off with something I think is really fun that Cristy is doing. I've got a slide pulled up on the other side, and I'll intro that real quick, Cristy. I'd love for you to talk a little bit about this before we get into our main talk. So let me just share my screen with you. And so this is something that I just heard about, and I'm looking forward to hearing more from Cristy. And it looks like a pharmacist.
Yeah, so Joe Moose is a fourth generation pharmacist and co-owns Moose Pharmacy with his brother Whit, but it was started over 100 years ago by a great grandfather or something like that. And so they've been community pharmacists before even, community pharmacy was cool. And it's still cool, even though everybody in the bigs is trying to put community pharmacists out of business. Big healthcare, big insurance, big hospitals, and big pharma would like to see community pharmacy go away. But I think Joe and I are going to have a great opportunity coming up in a couple weeks to talk about um, setting up local high performing care networks that become the building blocks of community owned health plans. And so why use Wall Street to, cover your employees' health care when you've pretty much got all you need right on Main Street? And
Wow.
so anyway, it'll be an interesting talk. It'll be at Health Benefits Nation in Nashville, Tennessee. And yeah, if you see that square circulating around LinkedIn or other social media, if you use the code CG50, it gets you 50% off of the registration price. And it's well worth it. There will be lots of very smart people there, not me, but everybody else.
Not true. Not true.
um, Lots of innovative employers and leaders in the health benefits industry talking about how do we restructure this thing so that it works better, the care is improved, and the cost goes down.
Why is that happening, Cristy? Like, why are there these new innovative folks in healthcare benefit management? Because before we didn't hear about this. Like, there was a good period of time that I felt like there's a level of satisfaction with our health benefits, and now it's coming under question pretty significantly. What's happening kind of throughout the nation that's caused kind of an uprising, and what are we doing with healthcare?
Yeah, the first person that comes to mind that is very outspoken and well respected and such an advocate for the people is a lady by the name of Cynthia Fisher. And she runs an organization called Patients' Rights Advocate. And she's really brought a huge awareness to um, price transparency, healthcare price transparency. And so about 3 years ago, a law was passed as part of the Consolidated Appropriations Act of 2021. These big omnibus bills at the end of every
Yep.
calendar year. They're really meant to fund the government, but they also may address other things. And this one certainly did. In 2021, it addressed a lot of inequities in healthcare, especially as it relates to secretive and punitive pricing arrangements with hospitals and insurance companies and the people that sell health insurance like brokers. None of that pricing was available and transparent. And so now, 3 years later, we're starting to see some of that reversed so that people can see what prices are before they consume the care. And it's in no small part to her efforts, Cynthia's efforts, and some of the other people that advocate for the same thing. So I think that Washington is finally listening, and some of that information is finally trickling down, to the consumer level, and people are starting to advocate for themselves and say, I want to know what this costs, and I want to know it up front, not 60 days later when you're surprising me with a bill that I can't pay, and not only a bill that I can't pay, but a bill that you can't even demonstrate to me that you even know how it is that you billed me that number. Right? So we're all having to get honest and advocate for ourselves in this healthcare system, because it's really set up. Some people say healthcare is broken. I disagree. I think it's working exactly the way the people who designed it to work this way. It's working exactly how that was supposed to work all along for them, not for us.
Right.
It's so funny you say that because I remember reading as a pharmacy student, looking into Never Pay the First Bill, was one of the
Mm,
books I was first introduced to, right? And it looks at paying a hospital bill or a clinical bill or a healthcare visit bill and seeing all the things that Christy was just describing there on
Mhm.
what is formulating that bill, what things are being accounted for, how are they being justified, how are the prices coming about, and what reductions can happen in place. Just this last week, I was fortunate to talk to a claims adjuster in the healthcare space, talking about how different healthcare entities are willing to oftentimes reduce their bills by 33 to 70%, upon what they're going to ask the individuals to pay. That's significant, Christy, when it comes to the amount that they're saying, I'm going to take this off with a reduction of price from what I'm charging you outright. And so I think, if anything, encouraging folks to at least look at their healthcare payments and see what can be reduced is a good first start. But for us to have a good first start, Christy, what is healthcare insurance like in general? And what are the different types of payment benefits that are out there and coverage overall? How do you define it? And what are the things out there that people are accustomed to seeing? And what should they know about?
Yeah, it's first, before I answer your actual question, I just want to say that, the late Marshall Allen, who wrote that book, Never Pay the First Bill, and actually the full title of that is Never Pay the First Bill and Other Ways to Fight the Healthcare System and Win. And he was always very upfront about that and saying, there are going to be winners and losers here. That's inevitable. But I want the people that read my book to win. Because sometimes this is a fight between good and evil, between transparency and opacity, and between, egregious billers and those who just want to buy healthcare that's high quality, but with transparency.
Well said.
So, you asked, I'm sorry, I hear an echo. You asked me about bills, what's real and what's not. First of all, I think it's important, as often as you can, to ask up front, like even before you have an appointment on the books, like maybe when you're calling to make that appointment. You may not always get the answer you're looking for, depending on what type of health insurance you have. Like if it has a BUCA logo on it, and when I say BUCA, I absolutely mean that as a 4-letter word. It stands for Blue Cross United Cigna Aetna. But if you have a BUCA logo on your card, you're probably not going to get the answer that you're looking for, because some of the people that are in those networks, the providers that you might be seeking care from, they've been sworn to secrecy, right? And that's, first of all, a problem, because that's not transparent. And you deserve better than that. But if you have some of these newer, um, more transparent health plans that are unbundled and have been designed on Health Rosetta principles, like utilizing open, transparent networks rather than a traditional PPO network, then you should be afforded the knowledge of knowing upfront what the price is going to be. And so I think that employees, patients, whatever, they should be advocating not only for themselves, but for others by saying, what is this price going to be? I need to know that before I arrive.
Mhm.
Um, and note also that even if you have health insurance, you're not required to use it. This is a free country. And even the Affordable Care Act gave patients the right to leave their insurance card in their wallet if they so choose, and pay either a cash price or a negotiated price, that, is maybe something more equitable to them, and whatever it is they need at that time. So if you want to just pay cash for something, you're not required to use your insurance, and you can leave it in your wallet if you want to, and don't be, sort of fooled or bullied into saying, or into believing that if you don't use your insurance, you can't get health care, because that's absolutely not true. Health insurance does not equal health care. Cash is still king. You're still allowed to be a self-pay patient. And, if people want a little more coaching about that, absolutely, they should pick up Marshall Allen's book and read it. There's a whole chapter on not using your health insurance if you don't feel like that's the right move for you at the time.
So, Cristy, and I hear a lot of what you're saying. I'm going back in time and thinking about some of the many phone calls I've had with health insurance for various family members, et cetera. And even still to this day, caring for my mom too, who's much older, in her 90s. So I can totally, from young children to myself, my husband, and then our parents, trying to make our way. So when we're thinking about that, and when you say, "Oh, you don't have to use your insurance card," and um, and you can just pay out of pocket. Oftentimes now, I'll even hear from doctors saying, "We can't see you because we're not, we don't have a contract with your insurance company right now," especially if they've moved or they've changed, who they're with, and they're still waiting for this whole contract to go through. I was just in the middle of one of those, waiting for an appointment and having to go through some various things. So when you say you don't have to use your insurance card, and so what can providers do in hearing that? Because maybe they don't necessarily know, but also the consumer, what can we do to be like, wait, I don't have to use my insurance card? To me, I think a lot of people wouldn't necessarily know that, both providers and patients.
Yeah. So that statement, it really does go system wide, but if you don't mind, I'm going to focus on primary care, if that's
Yeah,
okay.
please. Yeah.
So usually, or what really should be our first stop in the healthcare system, is a primary care doctor. These physicians are trained much more deep and wide than we even have been taught to realize. And in the modern day healthcare system wants you to believe that you should just skip over primary care and go straight to a specialist. And I absolutely believe the opposite. I think that you should have your personal physician on speed dial. And for that matter, there is absolutely no reason to insure primary care encounters. It's just not that expensive, right? I mean, I don't insure the steering wheel of my car, right? Or the front bumper or the rearview mirror, or I insure my whole car. So the risk sharing behavior that I participate in when I buy car insurance is to replace a catastrophic destruction of my entire car, right? But I don't buy car wash insurance or oil change insurance or any of those things. The everyday care that I take to maintain my car and make sure it functions properly is really not something I need to buy insurance for, so I don't. Why? Because it's already affordable, right? So um, I think that a lot of physicians and patients have started to realize that this is a thing, right? You don't need insurance just to get primary care. And if you pay for primary care a different way, then you can have even better, more fruitful encounters with your primary care physician. They can truly become your personal physician on speed dial. I kind of coined that phrase some time ago, and it really rings true, because indirect primary care not only is virtual care, um, the foundation, one of the foundations of direct primary care. So, like calling up your doctor out of the blue for no good reason, or maybe it's just that you have a question, or sending a text or an email, or doing FaceTime encounter, or taking a picture of something on your body, that you want your doctor to see. So, it was a couple summers ago, and I remember being out at the pool with some friends, and one of the other moms was out there, and she says, "Turn around, what is on your leg?" And it was in the back. I knew that I had something back there that didn't feel right, and it was itchy, but I didn't know it was a brown recluse bite.
Oh man.
And so she says, let me take a picture of that. You have one of those doctors, right? Where you can just call them anytime. So she didn't really even know what to call it. She used the word concierge. And while direct primary care is not the same thing as a concierge doctor, I
Sure.
still think that DPC probably it wouldn't exist if it hadn't been for concierge kind of paving the way.
Yeah.
And so I said, yeah, sort of. She snapped a picture. I texted it to my doctor, and he said, yep, it's a little hard to tell exactly what kind of bite that is, but either way, it doesn't look good. I'm calling you in an antibiotic. Go to, the pharmacy. It'll be waiting on you when you get there. So, sure enough, something that could have gone very badly had I ignored it or just not looked into it enough, or
Mhm.
just thought it was some kind of mosquito bite or something. It could have worsened and really been terrible. Instead, I had unlimited access to my personal physician on speed dial. And by the way, I remember this night. It was a Saturday evening, so and it was late enough that I wouldn't have wanted to get dressed and get in the car and go to urgent care, right? I'm just so thankful that I have the good thought to say to myself, Cristy, you just don't need insurance for primary care, right? And so I don't do it. As a consumer, as someone who wants to get the most out of the American dollars that I earn, I would rather pay for unlimited primary care in a membership basis where I just pay cash for that, an affordable monthly amount. And the national average for direct primary care is somewhere around the $75 a month mark. Might be a little higher in big metropolitan areas or a little lower in rural America. But that's pretty average. And so for an affordable amount like that, and you really just don't need insurance for that. And I'll take it one step further. As a insurance or a employee benefits advisor, of course, in my day job, I structure group health plans for employers that have a whole workforce that they need to take care of. But I, as an individual, there's really no good individual insurance options for me. So I decided to go with a health share. That's not insurance, but it's still a very viable and legitimate way for an individual to share their risk with other people in the same scenario. And it partners up very well, kind of like, peanut butter and jelly, right? With direct primary care. So I don't need insurance for primary care. And honestly, if I source the care the right way, I really don't need insurance for anything else. There are different ways to share risk with people, with pools of people. And so as an individual, I advocate for health sharing as long as you pick the right one. I mean, there's bad actors in all kinds of different places in the healthcare system. You have to do your homework. But I'm just one of those people who believes that you don't always need insurance for everything.
So I'm sure Donna has about 100 questions as well. So I'll try to keep mine brief here, Cristy. Going to the DPC model, since we covered that initially, the direct primary care. I've had several family members ask me about it because I've introduced it. It is an interesting secret, like overall, folks just don't know. It seems like more practices are opening up. Donna was just mentioning before the show that it's just kind of starting in Massachusetts that she feels. Same thing in Washington. I feel like there's a number of them out there. It's underutilized. And if you look at the numbers of these DPC clinics as they're starting, they're working as hard as they can to attain more patient bodies so they can sustain their practices overall. So the model, Cristy, can you break that down for us a little bit on what's the typical primary care model that we're going to see through a large healthcare system, and you're part of their primary care team, and you're seeing, your individual patient, you're seeing someone on their team versus having a relationship and the payment model with a direct primary care? How is that different? What are the pros and cons?
Yeah. So in typical fee for service, that's the phrase we use for insurance dependent healthcare services. You've got about 100,000 different codes through the ICD-10 system, or CPT codes if you're in a hospital setting or whatever. And so all that billing and coding, I personally believe that that diminishes the doctor-patient relationship. There's this great cartoon. I wish I would have emailed it to you ahead of time, so you could use it on screen. But it has this guy on the exam room table, and then a doctor uh, on the other side. But in the middle of the doctor and the patient is a third party, payer, like a health insurance company. And the doctor is having to look through the ear of the third party just to look through the ear of the patient. It's I'll have to send you that cartoon separately so you can put it up. But there's just it just feels like they're in the middle, in between the doctor patient relationship. Whereas if you take that third party payment mechanism out of the relationship, then that puts the doctor and the patient in a direct relationship with each other. And the patient pays the doctor directly, and the doctor doesn't have to go through a third party payer just to give you the health care that you need. So really, I think it boils down to that.
Yeah, I think
I
one thing
think,
Christy, I've got
yeah,
to
go ahead.
emphasize clinically is this. With the DPC relationship, one thing Don and I have experienced in the primary care world is a dilution that has happened. So you end up seeing a provider for 7 minutes, right, on average
Yeah.
overall. And if you see them for that amount of time with their head up away from a screen is pretty rare. And so you really have to be able to go into an individual clinical visit and not assume the clinician is going to take care of you, but that you have to make sure that you're getting the care you need, right? There's a real self-advocacy. I'm not saying that changes with DPC, but the length of appointments in the average DPC space, like we're looking at 30 minutes to an hour, for individuals to go in. I've seen some that are even longer for initial visits. And so the amount of time being spent in that intimate relationship building really brings us back to the black bag medicine kind of era of taking care of individual patients. Is there any concern, Cristy, when it comes to, I'm sure folks listening are like, oh man, but I work with this healthcare system and these providers are part of that, and these DPC providers are not. Like, what if I need care in the emergency room, or what if I need a referral over to a specialist? How do I do it within DPC?
Yeah, thank goodness that there are laws at our disposal that help everyone. So the law EMTALA, people talk about, that stands for the Emergency Medical Treatment and Active Labor Act. It was signed in the Reagan administration. And so that means that any human who walks into an emergency room is to be taken care of regardless of their ability to pay. So maybe they can pay cash or not. Maybe they have insurance or not. Or maybe, they have nothing. And all people are supposed to be treated equally, regardless of their ability to pay, in an emergency room in the United States. So, yes, that still means you still have to advocate for yourself. And even, let's say you have an insurance or a third party payer card in your wallet, but you're not really even sure what that gets you. Um, you still may have to advocate for yourself, right? I mean, you mentioned Marshall Allen's book, and let me just say how badly I miss him. The whole industry was rocked when he passed away in May. But if you go to his book, I used to have the page number memorized, but there is a little um 20 word sentence or something like that in the book, where even as a person with as much knowledge as we all have, I still have a little app on my phone that writes out the sentence for me, where it says, ask for the consent, right? If you're in a hospital situation, you are going to probably be given an iPad and asked to sign it with your finger. And the person who gives you the iPad is probably going to say, first, before we can treat you, we need your consent so we can treat you. And they shove this device in your face. Well, this is where we have to advocate for ourselves and just say, time out. Would you print this out for me, please? And when they bring you the printout, you need to find the paragraph or two that's the financial consent, because they buried that in there. And they're not necessarily going to come forth with, this is not only the consent to treat, but this is the consent for us to bill you anything we want to. And so that's in the financial consent. So if you find that, now this only works in the emergency room. I want to be clear about that. If you find the financial consent, you are allowed to cross through that and write in there what Marshall Allen wrote in his book. And I'm sorry, I would pull it down from my shelf that I have right here and read it to you, but I know that would take too long for me to navigate to the page. Just buy the book. anyway, he says, right, I consent to, I should have it memorized, but that's why I have that app on my phone. If anybody wants to go to the app store and get a Quizify to go, it's a great app. And it basically says, I consent to 2 times Medicare for appropriate treatment coded at the correct level. And oh, by the way, only after you've presented me with an itemized bill
I
showing
consent to
all of
appropriate.
the charges.
Is it this one, Christy? I consent to appropriate treatment and including applicable insurance payments to be responsible for reasonable charges up to 2 times the Medicare rate.
That's correct.
That's it.
So the secret is most hospitals, if they are being honest with you, they are making a profit at even 100% of Medicare. So 200% of Medicare is a steal for them. So stand your ground and know your rights. And be a knowledgeable healthcare consumer and advocate for yourself. Ask for the consent to be printed out, cross through the financial paragraph, write those words that Kevin just called out, copy it from Marshall Allen's book. And, that's just part of having to advocate in this, punitive, very predatory system that we live in. I'm sorry. It's just the facts.
So, Cristy, years ago, my daughter had to have surgery. And while we were there, I just learned probably about a year ahead of time how important it was to know whether or not the surgeon and the anesthesiologist were both covered on your insurance company. And so I asked this question, and it was pretty emergent, a surgery that she had to have. And I'm like, we're going to do this, but I just want to know, is the anesthesiologist also, part of the healthcare system here? And they were like, I've never had anybody ask me that before. I'm like, well, if you could let me know, I would greatly appreciate it. And so they did. They figured it out and they did get back to me. But those are the things, like, and sometimes you don't know until you hear a story or something of that sort.
Right.
So what I would love to know is, say that there are folks out there who do want to pursue this direct primary care route that you're talking about, and they find the docs in their area that are direct primary care. And I think they can also be PAs and NPs. It's whoever can be primary care, right? So whoever is a primary care agent, if you will, provider. What are the things that folks should be looking for? Or as a provider, what should providers be providing that we're certain that we're picking that right person for us, that we're not going blindly into an emergency department and going, sure, I'll sign away to anything. So what is it that primary care should be doing for patients, and what should patients know that they're doing? And what are those things we should be looking for to make certain we're making good choices?
Yeah. 2 online tools that I usually go to first. My first choice is always the DPC Alliance directory. So the Direct Primary Care Alliance is physicians all over the country that have adopted the direct primary care model, a membership model, a transparent, open membership model. You usually can find their fees, their monthly membership fees for you or your whole family right on their website in plain view and in public where everyone can see it, and it's always transparent. And so they have a great directory, and their directory is pure pure DPC only. So no hybrids, no concierge medicines, stuff like that. But the second place I go to is the DPC Frontier. And that is a heat map. It does, however, include concierge medicine and maybe a mid-level, like a PA or a nurse practitioner that is operating under a membership model, as well as physicians. So I like to start with the DPC Alliance directory first and then pivot over to the DPC Frontier map just to find out where these are. And it's growing rapidly. The other place where you're going to find great news and up-to-date, not only commentary, but announcements of new DPC practices opening up all over the country is DPC News. So Dr. Doug Farrago, who was one of the nation's first direct primary care doctors and very successfully ran and then sold his practice to the second generation in his town of DPC providers. And now he's just floating into, retirement, so to speak, but he still runs the DPC News, which is an online, daily news platform. And I'm grateful that he's brought me on as one of the contributors to the DPC News. So I committed to writing a column once a month for the DPC News, and they're always promoting the newest DPC practices that are popping up, and they are popping up. I think every week announcements in the DPC News 3 or 4 times a week promoting some new practice that just opened its doors somewhere. So it's exciting to see that growth is happening. And, some DPC doctors do maybe some common threads or common features of direct primary care would be you have, quasi 24/7 access to your doctor. I mean, I think it's all pretty much, yeah, hey, call me when you need me. But most patients understand that their doctors need to sleep. So they're probably not going to wake them up at 3 o'clock in the morning. But I have myself called my own DPC doctor at like 10:30 on a Sunday night. I remember when I had COVID, right? And I have type 2 diabetes, and I do take a long-acting insulin, just, a few units every night, just to kind of keep everything on a steady state, right? Mm-hmm. But the day I was in bed all day long with COVID, and I did not put one morsel of food in my mouth all day because I felt that bad. And so come 10:30 that night, I was texting my DPC doctor and saying, I don't want to take that insulin because any diabetic is going to do anything they can to not have, a dip, a low glucose, because that sucks. So I texted him. 30 seconds later, he was calling through to my phone and saying, okay, Cristy, I know you don't want to eat, but I really think you should, because you really don't need to skip that dose of long-acting insulin. And so I was like, fine, I'll eat. That's nice to the kind of care. Yeah, that's the kind of care that you can count on, when you are a member of that practice. So in direct primary care, they usually limit their patient panels to something manageable so that they can be attentive to one patient who just happens to need you at 10:30 on a Sunday night, right? So most panels for direct primary care doctors are somewhere around 500 patients, which is about a quarter, 25% of the typical patient panel in fee-for-service, because those third-party payers are squeezing primary care doctors so badly that they need to have a panel 4 times larger than DPC just to make ends meet, just to make a profit. So, but when you pay for primary care differently, and because like we established a few minutes ago that you don't need insurance for primary care. So when you just pay for it differently, you get better results from it. You have 24/7 access, same day, next day appointments, calls, texts, emails, FaceTime, whatever. And, it's just an altogether better experience. Yeah. Donna, when you were mentioning, or Kevin, it was probably you said, basically, in fee for service, visits have been shortened down to about 7 minutes, because if they have to happen in person in order for the billing and coding to rise to the level of a profitable patient encounter, then you have to come there in person, right? So you have to pay that copay. You have to sit in a waiting room. You have to sit in an exam room, and you have to go through that whole hassle as a patient in order for them to make money on you. But in direct primary care, the money's already made because you paid it in the form of a monthly membership. So everything just sort of works better. You get the attention you deserve as a patient, and you're able to build a relationship. And instead of feeling like you're put on this weird treadmill where you're getting advice that maybe isn't custom fit to your actual situation, it feels more like a collaboration instead. I remember when I was new with my direct primary care doctor, and we probably spent a couple hours sifting through my medication strategy. And I did some research on my own. He did some research. We came back together, and it felt really more like teamwork than that weird adversarial type of situation where it's the doctor just trying to do the best they can in 7 minutes and then get you out the door, as opposed to, hey, time is not an issue. We've got all the time in the world. Let's figure this out. And
I love that.
it opens up a lot of doors.
I really think that there's some interesting things, Don and Cristy, that are developing in the medical world. That we have places like ChenMed, right, that are using value-based care models instead of using fee-for-service models, right? And so they're seeing a very similar patient panel to what direct primary care is doing. They don't have the same billing process. Obviously, it's a little bit different, but you're getting a better relationship with the provider. We're seeing other models like what One Medical and Amazon are doing when it comes to another provider that is seeing you as a primary care provider, supposedly, and now you have a membership model that's in place. We also know that through a pharmacy, there's a lot of cash-based pharmacies that are out there, and there are a lot of opportunities for us just to utilize cash to pay for especially generic drugs. But I wanted to pivot the conversation really quickly to Christine, where you probably know I'm going already. Those are great, and those are cheap, right? So if we can say everybody that's listening goes, I'm going to get a direct primary care provider in some way, shape, or form. I'm going to start paying cash for my generic drugs. Pretty easy. And for the most part, those direct primary care folks can already do all the inexpensive labs and exams that are necessary for you to do on top of it. What about for everybody else, Cristy, when they're thinking, but I need that insurance to be able to pay for the emergency room visit and for the expensive labs and for the expensive drugs? What are your thoughts there on other options in the market for them to consider?
Yeah, sure. Before I forget about it again, because I didn't mention this even when the little square was up on the screen for the talk that Joe Moose and I are doing at Health Benefits Nation.
Yeah.
Joe and Moose Pharmacy are exploring a new sort of pilot project, bringing direct primary care right into the community pharmacy space. So not only is a provider there right on site inside the pharmacy, but a whole slew of free generic prescription drugs that are commonly used to treat people, also right there in the community pharmacy space at pennies on the dollar. Actually, I think about 75 drugs are incorporated into the DPC membership as, no additional cost. We're starting to bring in labs, and I've got some ideas about imaging too. So to bring those right into the community pharmacy space, that's part of the building blocks of these community owned health plans that we're going to be talking about at Health Benefits Nation. But one of the things that you're asking me is, oh, but what about the catastrophic? Right? I mean, haven't you heard people talk in the industry about why can't we buy insurance across state lines? Why can't we just buy catastrophic insurance? Well, here's a little secret. Even the BUCAs, and remember my acronym for that, Blue Cross, United, Cigna, Aetna, even those guys buy what's called stop loss insurance. Some people call it reinsurance. Some people call it stop loss insurance. It really is just the catastrophic insurance in any health plan design. So You've got maybe your network, you've got your out of pocket cost sharing structure with deductibles and copays and coinsurance. Part of that premium that is paid for your health plan goes to buy the catastrophic insurance. Now that doesn't come from household names. It's these companies that specialize in stop loss insurance, but it's even the bukas buy stop loss insurance. What they don't want most of the employers in this country to know is that they can buy stop loss insurance on their own. They don't need to buy it through Blue Cross, United, Cigna, or Aetna. You could buy it on your own. You just need a good advisor to guide you to the right companies that sell the stop loss insurance and then create for you a plan design around everything else. One thing I learned being part of the Free Market Medical Association that was, co-founded by Dr. Keith Smith and some other folks that are involved with that, and it's a nationwide organization now. They've got a chapter in nearly all 50 states. But I heard of a cool case study of a freestanding ER in Oklahoma City, Oklahoma, who has started offering a direct contract to employers who want to make sure that emergency room is in their employer network. And instead of using fee for service to bill an unknown and sky high, dollar amount, the employers who direct contract with that ER know exactly what the fee is going to be based on about 5 different parameters. So most ER visits are coded by level 1, 2, 3, 4, or 5. And so this Oklahoma City ER has basically portrayed a walk-in, fairly non-emergent emergency visit. That happens all the time, right? If you ask any ER doc in the country what number of encounters walk in there that really shouldn't be there, and they'll say like almost 30% really don't need to be in an ER, and maybe another 50% could have used an urgent care if they'd made the right decision, or maybe if the urgent care had been open.
Mm-hmm.
But maybe only about another 20 to 30% actually should be in an ER, right? So there are direct contracts that exist for emergency rooms where you don't even have to buy insurance for that either. So all kinds of innovative things are happening. But when you get the right advisor who can help you assess the risk of your workforce based on demographics, based on claims data, based on, some other ways to underwrite your risk, you could probably find out, hey, I have enough money based on what I'm paying to Blue Cross that if I just set aside X number of dollars for everyday care and then buy the catastrophic insurance with X number of dollars, and then pay a flat fee to the primary care membership-based primary care down the street for my employees that would like to use that option. I'm probably spending more than that in this fully insured program that is non-transparent and that goes up at double-digit rate, a trend of, double-digit increases every year. So I think that every employer in America really needs to start to be very introspective and take inventory of what they're spending on their health benefits every year, because whether you like it or not, all of those dollars, not just the employee contributions, but the employer contributions into a health plan, are considered employee dollars. Those dollars are considered employee money.
Mm-hmm.
I didn't make it up. It's in ERISA, the Employee Retirement Income Security Act, which oversees health plans in America. That it's just the way that it is. And to be a prudent fiduciary and making sure that you're providing the members of your health plan with prudently spent dollars to a fiduciary standard of care, it's just important that you put the right amount of effort into making sure that those plans are structured the right way and not overspending.
Yeah.
Where a big, Blue Cross, United, Cigna, or Aetna is profiting more off of your health plan than even the members of the health plan are.
Cristy, another thing that I want to just talk about, kind of went back to a little bit of you mentioning, because this is the med list. I do want to talk for a minute or two about the meds, and really interesting about, maybe there's some generics that are now being part and weighed into this type of payment, if you will, or monthly subscription. But what I'm curious about is, if you and you said that you spent some time with your doctor, like going through your medication history too and your medications, I'm hoping that we might be able to have people think more clearly, spend a little more time about rethinking the meds that people are taking and how long they've been taking certain medications for, and thinking a lot more about reducing inappropriate and unnecessary medicines in that whole deprescribing world that I am, that's near and dear to, I know, Kevin and I. So are you seeing that, and just, are there numbers out there through this new model that actually there's less cost of medications, maybe less number of medications per patient, more time, maybe reducing medications? Are there numbers like that out there, and is there that information?
Mm-hmm. One of my first clients that I took on after I started designing plans this way, there was a really innovative local independent pharmacy in that town, and they also had the ability to be a pharmacy benefits manager as well. So they had a really clear line between how they could price drugs. And so we came up with a scenario where, as long as the employees started with their direct primary care doctor, as long as the prescription came into the pharmacy through their DPC, and it was a generic, then they would price it based on what that pharmacy could acquire the drug at. Okay, so I'm not a pharmacist and I don't know all the acronyms, but I know that, drug acquisition cost is a thing. If that's a list that, lots of people get access to. But they even went a step farther. They said, look, we buy $100 million a year in drugs, because they also had a long-term care arm that they, a model that they did inside their pharmacy. So that gave them a lot of buying power, a lot more than I gave them credit for when they first told me that. I was sort of amazed. And so with that kind of buying power, they could buy, let's say, metformin, a 90-day supply of metformin for 17 cents. So if they pass through that 17 cents for 90 pills of metformin to my client, and then their revenue model was a dispensing fee, which they were happy. I was happy to set it higher than the normal dispensing fee, right? Something that made them happy, something that made the client happy. And certainly it was a happy coincidence for the plan's assets, because when you only pay, let's say the dispensing fee was $10. That's probably a little more than people are used to hearing about. But then the ingredient cost was only 17 cents. Well, $10.17 all day long is lower than the $25 that Express Scripts is going to steal from the plan, just because they can do that in an opaque scenario, right? So if we were smart enough to say, okay, for this list of like 2,000 drugs, we're going to share, we're going to absolutely pass through our acquisition cost to you as a benefit of this prescription drug benefit design. And we're transparently going to disclose to you what we bought that drug for on a per pill basis, right? And then every time your employee comes in the door to fill this prescription, which is, if we're going to fill 90 days worth of a trusted drug that's successful, that's doing the job that your prescriber intended for it to do, then we're likely only going to see that patient 4 times a year. So, but they were happy with the amount. My client was happy with the amount. We were all ready to try it out. And I think based on what I can tell, we were maybe only one of, well, I know we were the only employer plan that was doing it that way, in that area. I'm not even sure if maybe we weren't the only employer plan in the country trying it that way. Now, of course, there had to be, other sort of not typical PBM, but somewhat, separate PBM behaviors for all the other drugs and all the other pharmacies in the country, right? So we still gave employees access to a whole nationwide worth of pharmacies, and we made allowances for brand names and all those other things. But because the generics were done so uniquely, um, we ended up, after 2 years worth of claims data, having a per member per month benchmark of right around $14 per member per month. Now, the national average for prescription drug costs per member per month is over $100. So I don't know, any way you slice it, our little experiment worked. And the only reason why that kind of thing hasn't been taken up much more. This was sort of a homemade idea that we just decided we were going to do it, and that there wasn't necessarily enough technology, and we should have just, I don't know, taken out a loan or something to get some AI, technician to create automation around that. But it just goes to show you what you can accomplish when you just say, you know what, we're going to crack this nut and we're going to figure it out. And we did, as a matter of fact, a little write up. We did a little write up for the Journal of Managed Care and Specialty Pharmacy. I think that's the right name of that journal. And that was in like June of 2020. That article came out, and so I was happy that we got at least the opportunity to try something new and different, and just prove to ourselves, if nobody else, that if you try something interesting and it works, you should probably at least have the courage, to try something new. So that might have been a very roundabout way to answer your question, but I do think that it's important for not only benefits advisors, but employers who are serious about spending the right kind of money on their employee health plan, to say, how else can we do this? Can we bring this a little more in-house, utilize the friends and neighbors that we have just right down the street on Main Street, instead of subjecting our employees to the Wall Street, mega gods and health insurance and health benefits and all the bigs in healthcare. I think it's worth stating for the record, you can do this differently, and it can be a better care outcome for your employee and cost you a fraction as much.
I love it. I know that we're up on time, but Cristy, thank you so much for joining us. It was just excellent. Tons of good information. I think good takeaway points for folks. I know that doing this at the end of episodes, maybe I can just copy this and paste it for our snippet later, Donna. But direct primary care, other new models that are out there that are much lower cost. Cristy mentioned something about not paying for car wash insurance. I think it's a good takeaway for the audience there. Those that are currently being insured and see that as a major component of their cost of their primary care provider is a good thing to be able to look into. Some of the other aspects of cash-based models or other innovative pharmacy models to be able to pay for generic medications, a big one. We talked a little bit about Marshall Allen and the things that are happening within your healthcare bills and looking at your emergency room visits and reevaluating those bills. Please take a peek there. And then we're going to have an even deeper dive, I think, sometime soon, Donna, on what we do with all the rest of it and the cost sharing models and everything related. But Cristy, any last words as we depart today?
I think that I'll just throw out another little tagline that I came up with, and this is speaking to the employers out there. And so one of my famous taglines is, all it takes is a good advisor and a little courage. And, why do you need courage? Well, it's because change takes courage. I mean, it was a courageous experience for me to say, I'm going to get off of my husband's insurance through, the big carrier that his big employer is with, and I'm going to go in this other direction that is new to me, but I feel like it's going to work out, and I took a chance. So change just takes courage. But if you have a good advisor, you know, you can lean on someone with experience and let them do the heavy lifting for you. So I think that's probably where I'd like to leave it.
I love it. Well, thanks so much, Cristy, for your time. Really appreciate you. Donna, you travel safely, and we will talk to you guys next time. Have a great rest of the day.
Take care.
Bye, y'all.